Hello everyone, I am Dr. Anjum Rashid. Welcome to my YouTube channel. In this video, I will talk about fetal alcohol syndrome or fetal alcohol spectrum disorders. Fetal alcohol spectrum disorders result from prenatal maternal exposure to alcohol, and this include fetal alcohol syndrome, partial fetal alcohol syndrome, alcohol-related neurodevelopmental disorder, and alcohol-related birth defects. Fetal alcohol syndrome is the most severe form of the fetal alcohol spectrum disorders. Now friends, alcohol is the most common teratogen, and fetal alcohol spectrum disorder is the most common cause of non-heritable intellectual disability in children. Now I will discuss pathophysiology of fetal alcohol syndrome. When a pregnant woman drinks alcohol, it crosses the placenta and rapidly reaches the fetus. This results in equivalent fetal and maternal alcohol blood concentration. Fetus depend on maternal hepatic detoxification of alcohol because the activity of alcohol dehydrogenase in the fetal liver is less than 10% of that of the adult liver. Amniotic fluid also acts as a reservoir for alcohol, thus prolonging fetal exposure. Alcohol and its metabolite acetaldehyde can alter fetal development by disrupting cellular differentiation and growth, disrupting DNA and protein synthesis, and inhibiting cell migration. Both ethanol, that is alcohol, and acetaldehyde disrupt metabolism of fetal carbohydrates, proteins, and fats. Both alcohol and its metabolite acetaldehyde also decrease the transfer of amino acids, glucose, folic acid, zinc, and other nutrients across the placental barrier, indirectly affecting fetal growth due to intrauterine nutrient deprivation. Hypothalamic pituitary adrenal axis dysregulation and alteration of basal and post-stress cortisol level may also occur due to chronic fetal alcohol exposure. Now the clinical features of fetal alcohol syndrome. Now first, the alcohol withdrawal symptoms in a newborn. Neonates of women who have been drinking immediately before delivery may have alcohol in their breaths for several hours. Hypoglycemia and acidosis may be present. Agitation, hyperactivity, and marked tremors lasting 72 hours are followed by 48 hours of lethargy. Seizures may also develop in these babies. Now I will discuss the clinical features of fetal alcohol syndrome. Key characteristic craniofacial abnormalities include a smooth philtrum, a thin smooth vermilion border of upper lip, and short palpebral fissures, that is less than 10th percentile for each. Now, 2 of the 3 characteristic features are required for the diagnosis of fetal alcohol syndrome or partial fetal alcohol syndrome. Now, palpebral fissures can be measured using a small plastic ruler, and the distance between the endocanthion and the exocanthion is measured. Endocanthion is the point where the 2 eyelids meet medially, and exocanthion is the point where they meet laterally. Now, ruler should be angled to follow the curve of zygoma bone. Presence of thin vermilion border and smooth philtrum is scored using a lip philtrum scoring guide, which is shown on the right side. Now, score of 4 or 5 indicate fetal alcohol syndrome or partial fetal alcohol syndrome. Other significant craniofacial abnormalities in fetal alcohol syndrome include midface hypoplasia, microphthalmia, strabismus, and ptosis. Now, areas of the fetal brain which are most often affected in fetal alcohol syndrome include frontal lobes, hypothalamus, cerebellum, basal ganglia, hippocampus, and corpus callosum. Now, central nervous system and neurobehavior abnormalities in fetal alcohol syndrome include microcephaly, intellectual impairment and mild to moderate mental retardation, cognitive impairment, developmental delay, irritability in infancy, hyperactivity in childhood, or attention deficit hyperactivity disorder. There may be seizures, delayed or deficient myelination, and agenesis or hypoplasia of corpus callosum. Skeletal abnormalities are also common in fetal alcohol syndrome. These include radioulnar synostosis, flexion contracture, camptodactyly, apparent palmar creases, especially hockey stick palmar crease, clinodactyly, clipal field anomaly, hemivertebra scoliosis, and dislocated joints. Other congenital anomalies which may be present in fetal alcohol syndrome include cleft palate, heart defects such as apparent great vessels, atrial septal defect, and ventricular septal defects. Renal anomalies may be present, especially aplastic, dysplastic, or hypoplastic kidneys, horseshoe-shaped kidney, hydronephrosis, or urethral duplication. There may be DJOR sequence. There may be refractory problems such as myopia or astigmatism. There may be hearing loss in these children. Now, in fetal alcohol syndrome, growth deficiency is also prominent. Infants are small for gestation age, that is less than 10th percentile for weight or length. And there is also postnatal growth retardation. Now, the laboratory workup for fetal alcohol syndrome. If the diagnosis of fetal alcohol syndrome is uncertain, then workup may involve a chromosomal analysis, cranial neuroimaging, and cardiac and abdominal ultrasonography. Now, the management of fetal alcohol syndrome. There is no cure for fetal alcohol spectrum disorders. Medical care of the child with fetal alcohol syndrome is treatment for associated birth defects and intervention for potential cognitive and behavior abnormalities. Early intervention is necessary to optimize health outcome. Now, in the end, I will discuss the prevention of fetal alcohol syndrome. No level of alcohol consumption in pregnancy is known to be safe, and drinking in all 3 trimesters poses a risk. Women who are pregnant or who may be pregnant should abstain from alcohol consumption throughout the gestation. Thanks for watching this video. Please like, share, comment, and subscribe to my YouTube channel.